Good morning, folks. I hope everyone's settling in okay. I'm going to kick us off this morning with a few opening remarks and really excited to be here. My name is Ananthi Thaminayagam. I am currently the Acting Office Director of the Maternal and Child Health and Nutrition Office in USAID's Global Health Bureau. So once again, good morning, good afternoon, and good evening from wherever you are joining us today. I'm really pleased to be participating in this event. I recently joined USAID's Washington office after serving as a Foreign Service Health Officer for USAID in Tanzania and in Southern Africa for over almost 10 years. And in most recent years, I've actually had the honor to see this activity in action. So once again, it's a real honor for me to be here. Let me start by thanking MCGL for inviting me to speak about the importance of breastfeeding and perinatal mental health today. We're hosting this discussion both in honor of World Breastfeeding Week, which is celebrated in the beginning of August, as well as National Breastfeeding Month, which is commemorated throughout the month of August in the US. I also want to thank all of you for joining us for this important discussion, including our expert speakers, who you'll be hearing from in just a few moments. Alongside our partners at MCGL, USAID is really pleased to continue these critical conversations and explore how we can better support breastfeeding through the integration of perinatal mental health services in primary healthcare. We're excited to see the ideas and connections and insights that will undoubtedly emerge from our discussion today and hopefully after. As many of you know, and I believe that the evidence is quite clear, both for breastfeeding and mental health. They are critical areas that parents all over the world require support for both before and after childbirth. As a mother of three myself, who has struggled with both of these issues, I personally have benefited from such supportive programs. I also recognize that not all individuals have access to these vital services. Today, maternal mental health disorders are the leading complication of pregnancy and childbirth globally. Given this, USAID is integrating a perinatal mental health focus into our maternal and newborn health and nutrition programs. Breastfeeding has been a cornerstone of USAID's maternal and child survival program for over 4 decades, as research and evidence has shown that these are powerful interventions that can save lives of women and children all around the world. Breastfeeding, as we know, strengthens a baby's immune system and prevents infection and disease among young children. It also reduces a mother's risk of breast and ovarian cancers, as well as chronic diseases like type 2 diabetes and heart disease. Through USAID's investments, our breastfeeding program support lactating women through skilled breastfeeding counseling, and it also develops breastfeeding champions among community and family members through education programs. USAID researchers are also working to integrate support for the mental health and well-being of women into routine antenatal and postpartum care throughout the prenatal and postnatal periods. I think many of you know that common perinatal mental disorders, including postpartum depression and anxiety, can have significant and lasting implications for women's health and their quality of life, and have been associated with both mortality and morbidity outcomes in newborns and children. Evidence also has shown that women who experience these common perinatal mental health disorders, are more likely to report delayed initiation of breastfeeding, early cessation of breastfeeding, or perceived insufficient milk, preventing them from exclusively breastfeeding. While perinatal mental health can affect any women who have recently delivered a small or sick newborn are particularly vulnerable to depression and anxiety. As we begin to pay more attention to the plight of small and sick newborns, we also need to pay close attention to the needs of mothers who have experienced an obstetric complication herself and now has a preterm or low birth weight baby with special needs. To further advance this agenda, USAID supported the development of a global perinatal mental health theory of change, which offers a common framework that can guide future investments and programming to improve countries' progress towards widely accessible, high-quality provision of perinatal mental health care services. It's my hope that the discussion today will connect important stakeholders of these two critical issues so we can begin to work together to advance nutrition, maternal and newborn health, and mental health. It's also my hope that families across the world will increasingly be able to access the same type of supportive services that I've had the privilege to draw on when I've had my own children. By better integrating mental health into primary healthcare services, our partner countries have the opportunity to improve outcomes in many sectors, including for breastfeeding. I look forward to hearing from our esteemed speakers today and seeing how our connections could result in more holistic support for mothers, their families, and newborns during a vulnerable period of the vulnerable perinatal period. Thank you again to MCGL for hosting today's event and for having me. Now let me turn it over to Habtamu to introduce the next part of the event. Thank you again.
Thanks, Sanati. Hello, everyone. As Ananti mentioned, it's important to have a mental health friendly care support for mothers with perinatal mental health to successfully breastfeed. That's why the team for this webinar is making the case to supporting breastfeeding through the integration of perinatal mental health service in primary health care. In this presentation, I'll be covering an overview of breastfeeding. Next, Laura Fitzgerald, MCL Senior Technical Advisor, and Nina Kadka, MCL Newborn Focal Person, will share the connection between perinatal mental health and small sick newborn care services and breastfeeding and opportunities to explore the integration of perinatal mental health in primary health care. Lastly, experts from Ghana and Nepal will share country experience of the integration of perinatal mental health and breastfeeding in primary health care. Let me dive into the first presentation. Next slide. As you know, Alanti mentioned earlier, breastfeeding is the most cost-effective preventive health measure for child survival as well as maternal health. In addition to I'll start by saying breast milk is a safe and natural and nutrition sustainable food for infants. In addition to the nutritional value for infants that in breast milk has several benefits to children and women. As mentioned earlier, breastfeeding prevents common childhood illness and is key to child survival. Inadequate breastfeeding is responsible for 60% of child deaths each year. Breastfeeding improves mother-infant bonding, which is important for maternal mental health. Breastfeeding protects against cancer and improves birth spacing, which is important for maternal health. Therefore, scaling up of breastfeeding to new universal level could prevent more than 800,000 annual child deaths and 20,000 annual deaths from breast cancer. Many countries have made significant progress to increase exclusive breastfeeding rates, but they are still low in most countries. According to the 2022 Global Breastfeeding Scorecard, globally the exclusive breastfeeding rate has increased by a remarkable 10% over the last decade, but only 48% are exclusively breastfed and only 44% are initiated on breastfeeding within the first hour. Next slide. There are several barriers, enablers affecting the scale up and practice of breastfeeding. And this factor could be challenges at a policy level, a workplace or a health system level, or individual and community level, as you can see on this slide. To give you an example, at the national and subnational level, this can be like, countries who do have supporting breastfeeding policies, including political support, they have better breastfeeding rates. If there is lack of political commitment and limited investment to scale up breastfeeding intervention, then that affects the scale up of breastfeeding. It's common to have violation of the International Code of Marketing of Breast Milk Substitute because of lack of limited enforcement and monitoring of the BMS code, as well as the aggressive promotion by breastfeeding milk companies. The workplace also very important intervention to improve, to encourage mothers to extend, the duration of breastfeeding. For example, in a policy that gives adequate maternity leave for 6 months, maternity leave, but in most countries are going in that direction. Workplace policies supporting designating a safe breastfeeding space gives breastfeeding a break, and it just really enable mothers to breastfeed. There are also health system factors with regard to health care and support to enable mothers to breastfeed. For example, skill counseling, lactation support is important, and also low uptake of PHC is a barrier for scaling up breastfeeding. There are also factors at the health facility infrastructure level, having some of the supplies and the space to encourage breast milk feeding, especially for small sick newborn. There are also individual community level barriers like social cultural attitude and values, misconception about breastfeeding, as well as infant formulas, lack of community breastfeeding support, and shorter social media pressure are affects the practice of breastfeeding. Next slide. There are global guidance to promote, protect, and support breastfeeding. As you can see, there is a WHO global strategy on infant and young child feeding, including for low birth weight, the Baby Friendly Hospital Initiative that was released in 2018. There is an International Code of Marketing of Breast Milk Substitute, the nurturing care for everyone. MSG Momentum and country global leadership also has been supporting breastfeeding at global level as well as the country level. For example, providing technical assistance to integrate breastfeeding into antenatal, postnatal, and small sick newborn care and services. MCL developed a PHC checklist to guide facility to integrate the 10 steps of successful breastfeeding, prepared quality of care for maternal, newborn, child, and adolescent child, including breastfeeding quality standard statements. This is my last slide, and I pass to Laura to present on perinatal mental health breastfeeding. Laura?
Thank you so much, Habtamo. So I'm going to encourage us all to take a step back for a moment and to look at this photograph together. So most of us are very accustomed to seeing images of breastfeeding like this one. Here we see an apparently very happy mother with her newborn. She's looking really lovingly at her baby. The baby appears to be nursing really contentedly at the breast. And we're taught that this is natural, maybe even effortless, that women are born with a maternal instinct and that these are some of the most joyful experiences of her life. And often they are. Next slide, please. Except that sometimes they aren't. For 20% of women, so that's 1 in 5 women, experience what are known as common perinatal mental health disorders. And they include depression, anxiety, or somatic disorders during the perinatal period. And this is the most common complication of pregnancy and the first year after birth. And while breastfeeding is often a bonding experience between a woman and her baby, the relationship between breastfeeding and a mother's mental health is complicated. Next slide, please. We know that mental health conditions can influence the breastfeeding experience. Let's take a look together at the data here. So one literature review found that babies of women experiencing mental health conditions can be at increased risk of feeding challenges and can have a more difficult time bonding with their parents. In 2021, we at MCGL conducted a landscape analysis of common perinatal mental health disorders in low and middle income countries and found that there does appear to be an association between common perinatal mental health disorders and exclusive breastfeeding. For instance, in rural Pakistan, a prospective cohort study found that women with perinatal depression were significantly more likely to report insufficient milk, despite the fact that there was not an actual reduction in milk production, and were almost twice as likely as non-depressed mothers to stop breastfeeding at any point. This effect was even more pronounced when depression was persistent. And yet, despite this data, rarely does a mother's mental health enter the conversation around feeding choices. Next slide, please. So there we were just talking about how mental health can influence breastfeeding, but we also know that conversely, the breastfeeding experience can influence a woman's mental health. Difficulty breastfeeding can be incredibly stressful for women, as the ability to feed and nurture a child can often be the first measure of a woman's perceived success at mothering. We know that feeding demands and sleep deprivation can trigger anxiety or depression in some women. And in such cases, prioritizing women's mental health is critical. If a woman is too depressed to closely attend to her child and her family, everybody suffers. So this isn't just a personal issue, and it's not just a family issue. Expecting mothers to breastfeed at all costs overlooks the essential support required from medical providers, from workplaces, from family members, from society at large to facilitate breastfeeding success. We need structural supports, as Habtamu mentioned, like protected maternity leave, flexible work situations, and childcare that's close to the mother. These can be necessary to achieve and sustain continued breastfeeding. Next slide, please. It's also really important to recognize that every woman arrives at new motherhood with a unique set of life circumstances and challenges and stressors. This slide shows some of the contextual factors that contribute to her mental health in the perinatal period. So factors like the experience of violence or living in a fragile setting or food or housing insecurity. And you'll see that one of these factors is the health of the baby. My colleague Nina will talk in a moment about this, but we do know that there's a relationship between having a smaller sick newborn and a mother's mental health and breastfeeding. For instance, a study conducted in Rwanda found that half of mothers of small and sick newborns had poor mental health. And this makes a really strong case for integrating interventions to identify and address maternal mental health within small and sick newborn services. Over to you, Nina.
Thank you, Laura. So as Laura mentioned, 40 to 50% of NICU parents actually exhibit elevated levels of depression and anxiety. 20 to 40% actually depict also trauma symptoms. The next slide, please. With this in mind, the WHO, when it came out with the standards for improving the quality of care for small and sick newborns in health facilities in 2020, it mentions about small and sick newborns are fed appropriately, including assisted feeding with the mother's milk, and mothers of small and sick newborns are supported for exclusive breast milk feeding. Next, please. And we do know that mothers of ill infants often feel at a loss of control of their lives. Their babies are snatched away from them into some other place in the hospital, and they lose their role as a mother. Next, please. Leading to a situation where providing milk for their infants, actually, if you take that on, then mothers can actually cope with this emotional stresses surrounding the neonatal ward experience and gives them something tangible to claim for their infants. Next, please. In the same standards, emotional, psychological, and developmental support is already included in the WHO guidelines, and I have highlighted here in Burgundy, their families should receive emotional and psychosocial support. So the guidelines are already there. The next, please. In addition, in recent times, WHO came out with their recommendations on maternal and newborn care for a positive postnatal care experience. And screening for postpartum depression and anxiety using a validated instrument is recommended for almost all women. And also systems for referral diagnosis has been recommended by this document. So while the global documents are already predicting and guiding countries to move ahead with this integration, I would like to now introduce our next speaker, who's from Nepal, Dr. Basu Karki. May I have the next slide? Dr. Basudev Karki is a senior consultant psychiatrist, mental hospital, Logankhel, Nepal, and is working for the Ministry of Health and Population. He will be speaking to the as to what Nepal has been able to do or not do on this important topic. So over to you, Dr. Karki.
Thank you, Dr. Nina. Next slide, please. I am currently working in mental hospital, Nepal having difficult geographical terrain, It is divided into 7 provinces containing 77 districts, having population around 30 million, and annual birth is around 394,000 per year, having 80% skilled birth attendant. And currently there is the status of improvement in maternal mortality ratio, that is 151 per 100,000 live birth, but we still have the serious issue of maternal mental health, that is significant suicidal rate among women of childbearing age, that is 16% of death in women of childbearing age, that is 15 to 49 years is due to suicide. That is the statistics from 2008-2009 study in Nepal. Next slide, please. But there is some improvement in newborn health statistics in Nepal. That was the improvement in last 2 decades. But in last 6 years, we have stagnation in newborn mortality rate, that is around 21 per 1,000 live births. It shows that we have to work more in saving the life of our newborns. Next slide, please. We have the statistics of small and sick newborns in Nepal, that is around 14% birth is of preterm birth, and 18% is a birth of child having low birth rate, where there is 81,000 preterm birth per year in the country. Next slide, please. We have some studies regarding breastfeeding practices in Nepal. That was about 55% of newborns are put to breast within 1 hour of birth, but there is still a decline in exclusive breastfeeding in recent years, that is declining from 70% to 56% in current year. But there is some studies showing that there is a breastfeeding practice of small, sick, and newborns during inpatient and post-discharge period. There was only around 3% of the newborns getting expressed breast milk feeding during their inpatient and post-discharge, shows that there is a huge gap in exclusive breastfeeding in children, in newborns, when they are in inpatient or post-discharge period. Next slide, please. Taking the background of such conditions, the Ministry of Health and Population, Family Welfare Division had some initiatives. There is a document known as Nepal's Every Newborn Action Plan. It has the aim of reducing newborn mortality to less than 11 per 1,000 live births by the year 2035. We have some initiatives of establishment of level 3 new NICU, as well as special newborn care units throughout the country. And there is the study for quality care. That was the initiative of Family Welfare Division along with USAID Momentum Country and Global Leadership Project, which has some initiative or model of care regarding the such establishment. And there is some pilot project which will have some data regarding our current strategy. Next slide, please. There is some areas of hope because there is increasing trend of antenatal care in current years. We have some areas to work on perinatal mental health, where we are working about the breastfeeding counseling during the antenatal period, so we can integrate perinatal mental health during ANC period also. Next slide, please. We have the protocol. This is the revised protocol of ANC and postnatal care visit protocol, which has been increased the number of ANC as well as PHC visit. In such visit, we can add the perinatal mental health as well as the breastfeeding of small and sick newborns. Next slide, please. But we have the practice of having some issues of separating small and sick newborns when they get admitted in ICU or NICU, or their mother get admitted for any perimental conditions in mental hospital or the general hospital. We have the challenge of having proper newborn breastfeeding while anyone or mother or small or sick newborn get admitted. Next slide, please. There are documents which are the roadmap for Nepal safe motherhood and newborn health that has some mentioning about the mental health of the newborn child's mother. And there is another document, Nepal Every Newborn Action Plan 2016, but there is no mentioning about the perinatal mental health. So we have to revise our existing documents to focus the perinatal mental health as well as breastfeeding of newborn who are sick or small. Next slide, please. Next slide, please. Okay, we have the community program that is known as the Female Community Health Volunteer Program. We have the training course for them that includes the anxiety, depression, conversion disorder, as well as the alcohol and substance use disorder, which are the common mental health and substance use conditions in the country. We talk to our community health volunteers. So there is again another area of hope to integrate the perinatal mental health in the community also. Next slide, please. We have another document that is known as the ANC to PNC Continuing Care Guideline 2022. We have another document that is the Standard Treatment Protocol for Basic Health Services. These all the document include the ANC as well as PNC visits as well as care of the mothers. It includes the screening of suicide and self-harm as well as substance, including the alcohol use disorders during the ANC as well as PNC visits. Next slide, please. Though we have the unfinished agendas, we have to address the issues of stillbirths. We have to integrate the perinatal mental health in our current existing documents, as well as to address the distressed mother who are separated from admitted small and or sick newborns. Then we have to have some specific programs for the individualized lactation support and emotional and psychosocial support for mothers with perinatal concerns and perinatal mental health. So these are the areas of unfinished agendas where we have to work on. With this, I want to conclude my presentation. I hand over to
Thank you, Dr. Baswith. And I now invite Dr. Pernanka Bruce from Momentum Country Global Leadership Ghana. She will be speaking challenges, opportunities for integration of perinatal mental health breastfeeding in Ghana. Dr. Per?
Thank you, Hassan. Can we have the next slide, please? Right, so I will be talking about what we are doing as Momentum and then the country context as we have it in Ghana. So for the MCGL in Ghana, two main objectives are to improve client-centered care for reproductive, maternal, newborn, and child health, and family planning and nutrition care services. And this we are doing through clinical and quality improvement and capacity development. And underpinning this is improved data quality and use. Our second objective is to strengthen the policy and enabling environment for quality RMNCH, family planning and nutrition services. And you'll agree with me that perinatal mental health falls squarely within this space. Next slide, please. So in Ghana, there has been increased attention being paid to issues of perinatal mental health. Currently, studies have shown that the prevalence of prenatal and postnatal depression are estimated at 10% and 38% respectively. And for prenatal anxiety, this is estimated at 33%. Traditionally, mental illness in general has been treated mainly outside the orthodox health system using traditional medicine and spiritual rites, and people would resort to the orthodox medical system as a last resort. The issue of perinatal mental health, the burden has been elevated due to a lot of cyclical factors, which include poverty, food insecurity, migration, and gender-based violence. And currently in Ghana, our nurses and midwives are trained per the curriculum. It does not really cover perinatal mental health, but focuses more on general psychiatric issues. I should add that there are quite a lot of opportunities when it comes to perinatal mental health, and just want to delve in a few of our country indicators. We have, as Ghana, 88% of women who are accessing 4 or more antenatal care visits, and also postnatal care visits are at 87%. As has been highlighted, breastfeeding rates have been falling, and in Ghana currently, our early initiation of breastfeeding rate is at 58%, but that also presents then an opportunity to be able to improve this. Next slide, please. So in the past couple of years, there have been targeted initiatives towards improving mental health services in general. In 2021, Ghana was selected for the WHO Director General's initiative on mental health, and this looked at strengthening health systems to improve mental health services and to scale up these services across the country. Following this selection, the Ministry of Health approved a comprehensive essential health services package to include now mental health services, which was not a part of the service initially. A mental health board has also now been inaugurated to provide guidance for mental health services. And then for our national health insurance package, mental health conditions have now been included in the package of services. After the just ended conference on international maternal newborn health that was held in Cape Town, perinatal mental health has been identified as a key country priority by both the Ghana Health Service and the Ministry of Health. Currently, as it stands, mental health services are not provided in maternal and newborn health units across the country. And so these providers are really unable to screen or identify and diagnose cases and link these cases to care. Next slide, please. There are some key challenges that are highlighted and we face when it comes to perinatal mental health, and I should say mental health conditions in general. Mental health services are highly stigmatized in this country, and not just the conditions, but also even the facilities. For someone to be referred to a mental health facility, it is highly stigmatizing, and people would rather not go. They would actually just go as a last resort if other options have failed. These include faith-based, other traditional healing services, which they go to as a first point of contact. On the policy level and at a national care level, no deliberate efforts have been made at improving perinatal mental health. The general focus, as I have highlighted, have been on general mental health conditions. There is inadequate staffing generally for maternal newborn health, and specifically for perinatal mental health. Capacity is highly is lacking when it comes to perinatal mental health, screening, diagnosis, and treatment. And there's an uneven distribution of mental health facilities. You'd realize that these are more focused in the urbanized areas, and as you go out into the rural areas, they are highly lacking, and especially at the primary and sometimes secondary healthcare level. There's also insufficient supply of drugs and medications to manage mental health conditions across the country. Next slide, please. Despite these challenges, they present opportunities for integration of perinatal mental health care into various aspects of care provision for mothers and their newborns. Currently, the Ghana Health Service is looking to review the National Safe Motherhood Policy, and this is the document that guides the delivery of services for maternal health across the country, and it presents an opportunity for us to be able to integrate perinatal mental health issues and care into this document. It's currently lacking in the document as we speak. Also, the National Reproductive, Maternal, Newborn and Child Health Strategy will be reviewed and revised in the coming year, and that also presents an opportunity. Currently, pre-service training for nurses and midwives focuses generally on psychiatry. I should say nurses, community health nurses, and midwives focuses on general psychiatry. And so there's an opportunity for us to strengthen and to update these training curricula with the Nursing and Midwifery Council, which is the body that works on these curriculum for nurses and midwives, to incorporate perinatal mental health. So as these providers are joining the workforce, they already are equipped to be able to provide services to women who may face these challenges. CPD opportunities abound a lot in country. There are lots of virtual platforms, in person, on the job training opportunities for nurses and midwives who interface daily with pregnant women and adolescents. And they present opportunities to integrate perinatal mental health capacity building for midwives. Currently, the Momentum Country and Global Leadership is working with the NMC to see how CPDs can be focused on CADA and according to care that is provided by the practitioner. So this presents an opportunity for perinatal mental health to be integrated. And during antenatal care, we can harness the potential of what we call in Ghana the maternal and child health record booklet. So this is basically a booklet that it sort of addresses the woman, the pregnancy, through pregnancy, labor and delivery, and then for postnatal care. Currently, it does not have, it presents the opportunity for counseling and for management of the woman through her pregnancy. And there's no opportunity for perinatal health screening in this document as we speak, and this can be revised. So as midwives manage women through antenatal care through all these visits, we have 88% of women at least having 4+ visits. This can be an opportunity for screening and diagnosis and linkage to care. Next slide, please. Group A and C is an approach that the Ghana Health Service is looking at to provide antenatal care beyond the focused antenatal care that is currently happening. And this presents an opportunity also for sensitization of pregnant women, and not just the women, but their families and support systems that usually would come with them to antenatal, to be able to sensitize them on issues of perinatal mental health. So they can identify these and present early for care. Non-separation of the mother-baby diet, this has been mentioned, and support for early initiation for breastfeeding during labor and delivery and the immediate post-natal period is important if we are looking at integration. Breastfeeding support during the postnatal period is another opportunity for integration of these services. We are looking at when these mothers present for postnatal care, but also importantly in Ghana, we have a huge cadre of community health nurses who go out to homes of pregnant women who have delivered to provide them care, and they need to be equipped to be able to screen for these services and link them to care. And that brings me to the last point when it comes to referral networks, linking these women to care from the primary healthcare level to the secondary level where they will find care, and also referring them back within what we call the networks of practice in Ghana, which is a network that is of health facilities that support each other when it comes to referral and care provision. With this, I will hand over to my colleague, Haptamu, for the next session.
Thank you, Dr. Per. Now I introduce Jenny Salve, who is going to moderate the speaker roundtable. Jenny is Health and Nutrition Development Officer with the Office of Maternal and Child Health and Nutrition at UC Washington. Janice.
Hi, everyone. Wow, big round of applause for our speakers so far. This has been really interesting and really enlightening to hear from everyone's experiences, so thank you. And we're going to bring up our speakers now for a quick roundtable discussion. So hopefully, Dr. Pearl, Dr. Karki, Nina, Laura, if you can turn on your cameras, thank you. We're going to start with one question for everyone. From your experiences, what is the #1 action that really needs to be taken by countries, development stakeholders to improve the policy environment, capacity development, and implementation to start to strengthen the integration of perinatal mental health and breastfeeding or breast milk feeding support? So what would be, in around 30 seconds, your #1 action that you would recommend for countries and development stakeholders to take on? Nina, would you like to start for us?
Sure, Janice, thank you. I'll speak from the small sick newborn perspective. Right now, many countries, low middle income countries, after the WHO standards came out, are moving forward with adapting the WHO model of care, which includes linkages with maternal health as one of the key component of model. This is an opportunity not to be let go of, because as the country is now developing protocols, policies, and even capacity building materials to integrate small sick newborn care and perinatal mental health into these immediately. So not a moment to lose. That's for me, over.
Great, thanks, Nina. Laura, how about you?
Thanks. So I'm going to echo Nina. My one action to suggest would be that perinatal mental health is integrated as an essential component of comprehensive care for pregnant and postpartum women and their families. This means that it's part of mental health and reproductive health strategies, policies, budget allocations, and it's a core part of the training, as Pearl mentioned, for healthcare workers. Thanks.
Wonderful. Dr. Pearl, what would be your one action you recommend?
Yes, for me, the one action I would recommend is really sensitization and education of the key stakeholders on issues of perinatal mental health. This includes the policymakers, the practitioners, and especially the communities, including opinion leaders. Recognition of perinatal mental health and the need for care, I think, is really crucial if we are to improve care for perinatal mental health and also breastfeeding in affected women and their babies.
Great. And Dr. Karki, how about you?
Yeah, we have to revise our current existing policies, strategies in line with the WHO guideline. Then we have to integrate the perinatal mental health services to community, to health institutions, and we have to establish recording, reporting, as well as clinical supervision and mentoring, along with the capacity building of health workers who are working in a community level as well as hospital setup. Thank you.
Thank you, Dr. Karki. And actually that lends well to my next question for you all. Hearing from your presentations and from your answers just now, that capacity building of health workers is so important. And so from your experiences, what would be your one piece of advice to people who are looking to start capacity development activities and targeting cadres to address maternal mental health and breastfeeding support? Dr. Karki, would you like to start this time?
Okay, thank you for nice question. Capacity building should start from the community level. In context of Nepal, we have the community health volunteers. Then we have to start with the capacity building of them. Then it has to go up to the policy makers, because in different documents we are missing the priority agenda, because we have the statistics that suicide is the first leading cause of death in women of reproductive age group, but we are not having any activities to address us priority data and huge mortality status in the country. So we have to have the awareness raising starting from ground to ground, that is from community to policymakers. Thank you.
Great. Yeah. Keeping in mind that wide lens of who needs the capacity building. That's great. Dr. Pearl, what would be your one piece of advice for those who are looking at capacity building?
Yes, I think for capacity building, as Dr. Karki has mentioned, starting from the community is extremely important. And we need to keep in mind that sensitization, not just for the providers, but for the community and the support systems, we should not underestimate those, because those could pose huge barriers to accessing care. We can build the capacity all we want, but if the care is not being accessed, then we have a challenge. And so that must be comprehensively addressed. And these should be incorporated into the capacity building that is planned for the health providers, so they can adequately support the women and families in the communities that they serve.
Yes, thank you. Wow, such an important point to keep in mind, accessibility. And so thinking about that as we target those daughters. So thank you. Laura, what would be your advice?
So I think my advice would be around taking the time to do some thoughtful co-creation work at the very start. I think it's really important that we start by asking women and families what they want, what providers need before we introduce any kind of capacity building interventions. We need to know what kind of support would be most meaningful in a given stressful situation for these families. We shouldn't assume that what's a priority in one setting is automatically a priority in another, or that terminology that's appropriate in one setting is automatically appropriate in another. The other thing that I would mention is that we also need to be asking about and addressing providers' own mental health needs as we continue to sort of ask more and more of them. Thank you.
Thanks, Laura. Yeah, providers' mental health needs. And what about lactating providers' breastfeeding support needs? So that's a good one to keep in mind too. And Nina, we'll wrap up with you. What would be your piece of advice?
I think Laura and Dr. Pearl and Dr. Karki said it all. One thought that's coming to my mind is that most of the capacity building materials for maternal, newborn, and mental health are working in silos right now, and we do not know how to bring it together. So maybe there needs to be some level of co-design, as Laura said, in bringing saying what are the simple interventions that can be done for perinatal mental health that can be integrated within MNH programming. That is an area that can be taken, action can be taken immediately, and work can start. Over.
Wonderful. Well, thank you so much. I know there's many questions from the audience for you all as well. So I will hand it over to Habtamu to go to our question and answer section. So thank you all so much.
Thank you, all the speakers, and thank you, Janice, for moderating the session. So it's time to answer, question that are posted in the chat box in the Q&A. Our team has been trying to respond to some of the questions, but there are questions that our team will respond. So the first question is says, thank you for an excellent presentation. Please, when is the best time to commence psychological screening support to expectant mothers during antenatal or postnatal period? Laura?
Thanks, Habtamu. So the WHO recommends screening in the pregnancy and postpartum periods. We can think of this roughly in thirds, that about a third of women with perinatal mental health issues arrive in pregnancy with those conditions. About a third start in pregnancy, and another third start in the postpartum period. So I think it's important to be taking that continuum of care approach and ensuring that we're screening in both, with the caveat that screening should really only happen in the context of where there is advanced support and treatment available for women who need that care. Thanks.
Thank you, Laura. The other question is, in most developing countries, there isn't adequate paid maternity leave, and health facilities are not very friendly. So what effort are you doing to improve these factors? Dr. Karki and Dr. Pearl?
Okay, thank you for the question. Yeah, we are providing 98 days maternity leave. It is only in government institutions and some of the private companies. Most of the private companies are still not providing such leave for the mothers. So we have to think about the mental health of mothers who are taking care of newborn, and they have to have the right of exclusive breastfeeding of newborns. So in countries like us, we are struggling for the breastfeeding right of newborn as well as the leisure of working women. We are getting some facilities, but it is not well recognized in other private sectors also. So we have to work on it. Thank you.
Thank you, Dr. Kirk. Dr. Pearl, can you
Just to add on,
the experience from Ghana?
Right. So as you had already mentioned, we know that the antenatal and postnatal time off for maternity leave is not enough. If we are looking at exclusive breastfeeding for 6 months in Ghana, is only for 3 months. And so there's a disconnect both for the mother and even for health practitioners who have babies who have to go back to work. What is happening is a lot of advocacy. So from Parliament, from the Parliamentary Select Committee to see if the maternity leave can be increased. That has been going on for a long time, a lot of advocacy ongoing. But beyond that, I think that individual, should I say organizations, especially private facilities, private organizations have made some space for mothers to be able to come in with their babies and be able to breastfeed. We have quite a few of them who have provided spaces in their offices, and so that even after the 3 months, mothers are able to come in with their babies and then they are able to breastfeed, or at least provide spaces where they can, express breast milk, etc. Beyond that, I think that what we have done also as MCGL is to work with facilities, because the question is addressing baby-friendly, if facilities are baby-friendly, to be able to incorporate the 10 steps into service provision, 10 steps for baby-friendly into service provision from antenatal to postnatal. So for the parts of the northern Ghana where MCGL is implementing, we are working with the facilities to be able to improve on this, so care for mothers and especially breastfeeding is improved. Thank you.
Thank you, Dr. Pearl. The other question is Laura, if you can take this one, is there data on breastfeeding experience of women who experience mental health conditions? Because it can help clinicians better personalize breastfeeding and mental health counseling in primary health care.
Yeah, sorry. So there definitely is data around the prevalence of mental health conditions in the perinatal period. We know that it's about 1 in 5 women in low and middle income countries. And there are a lot of successful models of how it can be integrated within the primary health care setting. I saw another question about whether this really requires specialist care. It does not. This screening and initial care and counseling can be provided by non-specialists, that's midwives, and even community healthcare workers in some settings, depending on the country and depending on what the health workforce looks like and what cadres are available to support. The other point that I wanted to raise is I saw another question around adolescence, and I wanted to apologize for using the term women exclusively. This is an issue that really affects adolescent mothers in particular. They have a 3 times higher risk of common perinatal mental health disorders as older women. So we do want to be thinking about especially how to reach younger mothers, and often that is in the community setting. Thank you.
Thank you, Laura. The other question is there room to include private sector, especially in breast substitute policy in country because they are influential? Definitely, I think there's any support, especially the implementation monitoring of the BMS code should involve private sector, because these days, most women are going to private sector for delivery and as well as neonatal care. So definitely both public sector and private sector should be involved. Another question probably for Dr. Karaki is, do you find when mothers receive good help to breastfeed that there are few problems with mental health? Dr. Karaki.
Okay. In country like us, developing country, we encourage mother with mental health conditions who are active on treatment to have breastfeeding through their newborn child. There are few psychotropic medications who are restricted for child breastfeeding. So most of the medicines are safe for the breastfeeding mothers. But this is the decision to be taken by the specialist. When we deal with the breastfeeding mothers, we encourage our health workers to consult with a specialist. Thank you.
Thank you, Dr. Kaki. We can respond to one question. This is for Nina. Is there any evidence of mental health and malnutrition associated with mother's infanticide? I think probably if you respond from the small sick newborn feeding perspective, and Laura, if you can jump on with regard to malnutrition for security.
Thank you, Haptamu. There's definitely an association between malnutrition and the maternal ability to breastfeed, and also with mental health. So this is an underlying factor. And mothers who are malnourished or younger in that case are the ones who actually have babies who are small and sick. That's an underlying factor too. So there's a close relationship between the two. And the fact that the mother is unable to breastfeed because of malnutrition, it can also result in a child who grows up to have growth retardations. Thank you.
Thank you, Nina. Laura?
Yeah, no, I think Nina said it very well. I think that then becomes kind of a compounding set of risk factors, right? So in the setting of food insecurity, we know a risk factor for maternal mental health conditions. It's also, if a woman isn't getting enough calories for herself, she's going to probably have a harder time breastfeeding. And then subsequently a child is at risk for growth issues. And this is where we see sort of the intergenerational impact of perinatal mental health issues. Thanks.
Thank you, Laura. So I think this that's all the question we have to answer. So most of the questions are also answered through the Q&A chat box. I would like to thank all the presenters and also the facilitators for the insightful presentation, also the question from the participant. This is not, as you can see, there are a lot of issues to answer for learning, but also it's time to really integrate perinatal mental health, breastfeeding, small sick newborn, and even other care as part of continuum of care. So it's just, to elevate the importance of perinatal mental health and supporting mothers' perinatal mental health, small sick newborn are really supported to breast milk feeding, because this is a major challenge. So I think this webinar has probably created interest and also opportunity for countries to take up, this challenge. Thank you all. And with this, I think we can end today's webinar.